Alrighty, well, welcome once again to today's webinar about characterizing eosinophilic gastrointestinal diseases south of the esophagus, featuring Dr. Nirmala Gonsalves. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. We're pleased to have Dr. Gonsalves join us today. She's a professor of medicine in the Division of Gastroenterology and Hepatology at Northwestern University, Feinberg School of Medicine. And she's the co-director of the Northwestern Eosinophilic Gastrointestinal Disorders Program. She has co-authored more than 60 manuscripts and is presented at more than 40 national and international meetings that focus on eosinophilic gastrointestinal diseases, also known as EGIDs. Her research and clinical career is dedicated to improving the care of patients with these rare disorders. Welcome, Dr. Gonsalves.
Thank you, Jennifer, and thank you to APFED for the invitation. Good afternoon or good morning, depending on where you're joining us from. My first challenge is to share my screen here, and hopefully you'll be able to see my talk. Give me just a moment. Okay, can everyone see? Jennifer, can you see that?
It looks great.
Okay, perfect. Well, thank you. I will be going over the topic characterizing eosinophilic gastrointestinal diseases south of the esophagus. Here are my disclosures, none of which will be relevant to the talk today. What I've been asked to do with my time is to review with you research on the nomenclature and classification of these disorders. We'll highlight a little bit about epidemiology. We'll review the clinical presentation, histologic findings, and endoscopic features. I will highlight a bit about the impact on quality of life of these conditions, and we'll review what we know about the natural history and disease course. So before we get started, I just wanted to do a quick review of GI anatomy in terms of terms that you will hear throughout this talk. So when we look here, we first see the esophagus, which is a long skinny tube that connects the mouth to the stomach. We then see the stomach, the top part, the fundus, the body, and the antrum. This then is connected to the small intestine. Oops, hang on 1 second. This then is connected to the small intestine, the duodenum, the jejunum, and the ileum. We then see the colon, starting off with the cecum, the ascending colon, transverse colon, descending colon, sigmoid, and the rectum. So how do we currently name eosinophilic GI disease? So version 1.0, or what used to be, was if disease was isolated to the esophagus, we called it eosinophilic esophagitis, or EOE. If disease involved both the stomach and the small intestine, it was called eosinophilic gastroenteritis. If it was isolated to the colon, it was called eosinophilic colitis. However, there was quite a bit of confusion over this term eosinophilic gastroenteritis and how it was being used. And this really highlighted the need to update this EGID nomenclature. This was a questionnaire that was given to over 80 experts in the field, asking them, when I use the term eosinophilic gastroenteritis, I mean to indicate that the disease involves. And what you can see here is that 40% of people actually used it correctly. They used it when they were referring to the stomach and the small bowel, gastroenteritis. However, 10% referred to it as any location along the GI tract. 10% looked at any combination along the GI tract, but not the esophagus. And you can see here in this diagram that there were numerous other answers. And it really highlighted that there was a lot of heterogeneity in this terminology and a lot of variability in the clinical use, as well as variability in that medical literature. And this really lack of precision, both in clinical practice and in research. Because the questions came up, does eosinophilic gastroenteritis refer to stomach or intestine, or both stomach and intestine, or other parts of the small intestine? So there was a need for standardized terminology to move the field forward. We needed to have a common language. As you all know, there are no clinical guidelines yet for non-EOE EGIDs, and the first step was to establish this common nomenclature. And this was a very large undertaking spearheaded by the Seeger Group with over 80 experts in the field. This came up with the International Consensus Recommendations for Eosinophilic Gastrointestinal Disease Nomenclature. This was published in the Clinical Gastroenterology and Hepatology in 2022. This was an international consensus process. 85 participants completed that initial Delphi round, and a Delphi round is just basically asking people if they agreed on these statements, if they agreed with these recommendations. There were experts from 5 different continents, North and South America, Europe, Asia, and Australia. There were numerous experts, gastroenterologists, allergists, pathologists, both adult and pediatric, and a range of researchers. So what came out of that was retention of existing nomenclature whenever possible. So for instance, the abbreviation EO was used, similar to eosinophilic esophagitis, EOE. We're recommending the use of EO for EOG, like eosinophilic gastritis. There was de-emphasization and redefinition of the term eosinophilic gastroenteritis. And there is an expectation that this nomenclature can evolve in the future, but we need a common starting point. So let's look to see what this actually looked like. So there is going to be an overall disease category. So all of these disorders will be referred to as eosinophilic gastrointestinal disease. If disease is isolated to the esophagus, it will be called eosinophilic esophagitis, or EOE. That's no different than what's been used for years. Any other location involved will be referred to as non-EOE EGIDs. And then there will be some additional precision. For instance, if involvement includes the stomach, it will be called eosinophilic gastritis, and you'll see here the EOG acronym. Involving the small bowel, eosinophilic enteritis, EON, and in the colon, eosinophilic colitis, or EOC. Looking at this in a pictorial way, this is the updated EGID nomenclature. So again, we have eosinophilic esophagitis, EOE, isolated to the stomach, eosinophilic gastritis, EOG, isolated to the intestine, EON, and within EON, if we know the specific location, for instance, in the duodenum, it will be called eosinophilic duodenitis, EOD, jejunum, eosinophilic jejunitis, EOJ, or ileum, eosinophilic ileitis, or EOI. And isolated to the colon will be eosinophilic colitis. Now, there was really good and excellent agreement on these terms here. Where there was a little bit of disconnect was when there was multiple regional involvement. So for instance, if you had a patient with involvement in the esophagus and the stomach, recommendations are to call this eosinophilic gastritis, EOG, with esophageal involvement. That's the preferred terminology. However, it can be referred to as EOE and eosinophilic gastritis. The confusion here is that the traditional term EOE is disease isolated to the esophagus without any involvement in any other organs, without gastric and duodenal involvement. And that's why there was not clear consensus on how to name these multiple regions. If you have involvement in the stomach and the small intestine, the preferred terminology is eosinophilic gastritis and enteritis. However, you can use the term eosinophilic gastroenteritis if you are using it to involve both the stomach and the intestine. And if you have combination intestine and colon, it will be eosinophilic colitis and enteritis. The other thing to note is that EGIDs can involve all layers of the GI tract. So it can be mucosal, muscular, or serosal. So what you're seeing here is a cross-section of the gut. And the gut is basically a long tube, whether or not it's the esophagus, the stomach, or the intestine or colon. And the tube is like a donut, with the inner portion here, which is the superficial layer, deeper layers of the muscle here, and the outermost layer of that donut, that's serosa. The superficial layer is considered the mucosa, deeper layers the muscular mucopria, and the outermost layer the serosa. The most common eosinophilic infiltration in terms of EGIDs are mucosal disease, followed by muscular disease, and the least common are diseases involving the serosa. Now, we think of non-EOE EGIDs as being quite rare, but how rare are they? This was studies based on insurance database claims looking at EGID prevalence, with a prevalence of 6.3 per 100,000 in eosinophilic gastritis, 8.4 per 100,000 in eosinophilic gastroenteritis, and 3.3 per 100,000 in eosinophilic colitis. And again, this is older nomenclature because this was all research before the new guidelines in 2022. Now, taken out of context, these numbers may not mean much, but if you put it in context with other eosinophilic diseases like EOE, which has a prevalence of 45 to 104 per 100,000, just how rare these disorders are. But this might be changing based on data from the Seeger group led by Dr. Pesek, pooling all the data from 8 to 10 different centers in the country. And what you can see here is that there's really an increase in the number of patients being diagnosed with these conditions over the last decade. And irrespective of the type of condition, eosinophilic gastritis, enteritis, gastroenteritis, or colitis, all of them have been increasing over this time. Now, this is similar to what we saw with EOE about 10, 15 years ago, but that rate of rise or that trajectory is not quite as steep. Let's move on a little bit now to clinical presentation of these conditions. So follow-up data from the Seeger group looking at all of the patients with non-EOE EGIDs. They had 373 subjects, 317 children. And what they found was that there was more of a 1-to-1 male-female ratio. And that's a little bit different than EOE, which is about a 3-to-1 male-female ratio. Average age at diagnosis is in the third decade, so about 36 years, and that's similar to EOE. And 50 to 70% of patients had atopic conditions or other allergic conditions like asthma or allergic rhinitis or atopic dermatitis. So slightly less than what's seen with EOE, which tends to be more in the range of 70 to 80%. The Seeger group and the Dr. Rothenberg's group at Cincinnati Children's have also done a little deeper dive looking at the genetic analysis and doing some comparisons with EOE. And they found that the genetic analysis has identified that less than 10% of the EOG transcriptome overlaps with EOE. What you can see here on the right panel is a heat map of the genetic transcriptome, and you can see a lot of preserved genes across, but there are some definite unique genes. The similarities included Th2 immunity, eotaxin 3, mast cell transcriptome, and increased cytokines, including IL-4, IL-5, IL-13, and IL-33. We also know, based on the Seeger study, that resolution of gastritis and duodenitis with elemental formula, so just a food allergy-driven condition. So again, some similarities with EOE. We know that symptoms can vary by organ involvement. So if we have eosinophilic gastritis involving just the stomach, the clinical symptoms that patients often have include abdominal pain, nausea, vomiting, early satiety, which means you feel full more quickly when you're eating, and diarrhea may be present. When lab work is tested, you can see a low blood count. Oftentimes there's high eosinophils in the blood. There can be low protein and low iron. If imaging studies like CAT scans or barium studies are done, you can see gastric thickening and narrowing of that pylorus called pyloric stenosis. And atopy or other allergic conditions are typically present. What about eosinophilic enteritis? Well, they have similar clinical symptoms, but then start to have more diarrhea and bloating, depending on the percentage of intestine involved. Lab testing is similar, but they can have more profound low protein and low iron, particularly in cases of protein-losing enteropathy. Imaging can show small bowel thickening or strictures or narrowing, and atopic conditions are typically present. With eosinophilic colitis, you tend to see more diarrhea and even rectal bleeding. Anemia can be more profound, so low blood counts. Imaging may show some colon thickening, and atopy is not as common as patients with eosinophilic gastritis and enteritis. It's important to also know that symptoms vary by tissue layer involvement. If you remember that picture of that donut and the layer that the eosinophils are penetrating. So if it's just the superficial layer, the mucosal variant, this is the most common type. Patients will have decreased appetite, that early satiety, nausea, vomiting, and abdominal pain. And if you have a lot of small bowel involved, you can have problems absorbing different nutrients or malabsorption, a failure to thrive, and that protein losing enteropathy, meaning losing a lot of that protein in the gut because it's not getting absorbed. If you have the muscular variant or that thicker variant, you can have wall thickening of that gut, impaired motility, and is also a rigid gut. You can have symptoms of intestinal obstruction, including nausea, vomiting, abdominal distension, and gastric outlet obstruction, particularly if you have that narrowing of that pylorus, which is the opening from the stomach to the small intestine. The serosal variant is the least common type. This can have isolated ascites or ascites in combination with mucosal or muscular EGID. And that ascites or belly water, if you were to tap it or take a sample of it, it shows a lot of eosinophils in that fluid. What about histology? Well, histology can be a little bit tricky in the lower EGIDs, mainly in the esophagus. Any eosinophil there is considered abnormal, but there are normal numbers of eosinophils in the rest of the gut under normal circumstances. So how many eosinophils are too many? In the esophagus, we know and we recommend that over 15 is considered that criteria. The Seeger Core, headed by Dr. Collins, is doing a lot of work on trying to develop diagnostic guidelines for the histology for the rest of the gut. In EG, the current recommendations are for over 30 eosinophils per high-powered field in 5 high-powered fields. In eosinophilic enteritis for the duodenum, the recommendation is over 30 in either 3 high-powered fields versus a higher number in just 1 high-powered field of over 52. In the lower intestine, it's over 56. And the colon has different numbers because the normal numbers of colon, the eosinophils in the colon vary by location. So on the right colon, we want over 100, and the transverse and descending colon over 84, and the rectosigmoid over 64. So this is a bit of a moving target as we develop those consensus guidelines, but right now, these are the recommendations in terms of that threshold. There's a broad differential diagnosis for EGIDs. There are many things that can create tissue eosinophilia, including infections with intestinal parasites, particularly strongyloides. So it's important to evaluate patients for these infections if you're considering this. Malignancy can have eosinophils in the gut, inflammatory bowel disease, vasculitis, hypereosinophilic syndrome, and other disorders listed here. This slide just really highlights that not all eosinophils in the gut are EGID. We really need to put this in the right clinical context in order to make that diagnosis. Again, I mentioned that we don't have diagnostic criteria yet for EGIDs below the esophagus. This is in evolution. And there are many questions that have come up. Is mucosal eosinophilia sufficient for that diagnosis, or are there other clinical features that are necessary? So we know with eosinophilic esophagitis, these are chronic immune disorders, and it's a clinical pathologic diagnosis. So similar, EGIDs south of the esophagus, we need to have symptoms as well as eosinophils. And the next thing that's been raised is chronicity. We think about these as being chronic disorders. So an element of chronicity is probably needed to make sure that this is not some isolated involvement of eosinophils. Other features here, and I won't go into great detail, but have been talked about, in terms of being included in this diagnostic criteria. Certainly eosinophils will be important. Do other features in that tissue, such as mast cells and lymphocytes, will they play a role? Other signs of tissue injury like cryptitis or inflammation of those crypts under the microscope, will that play a role? Endoscopic features can clue us into these disorders. Those lab abnormalities I mentioned earlier. Certainly radiologic features and genetic abnormalities can be included, and certainly disease complications like ulcerations and bleeding and perforation. So there is a lot of active discussion right now among the researchers in the SEGR group trying to develop a very comprehensive diagnostic criteria for the non-EOE EGID, so more to come on that. What clues us in as gastroenterologists to features of non-EOE EGIDs? Well, this is data from Dr. Hirano and the SEGR group looking at features in the stomach. This is the Eosinophilic Gastritis Endoscopic Reference System, or EGREFS, similar to EOE-REFS, which is a tool used in the esophagus. And these are the various features that are typically seen in patients with eosinophilic gastritis: erosions and ulcerations, granularity, raised lesions, erythema, thickened folds, friability, and stenosis, so EGREFS here. And I'll walk you through what each of these look like. So in terms of the erosions and ulcerations, they can be very subtle, so less than 5 erosions here. Over 5 erosions, you start to see superficial ulcers or breaks in this mucosa. A deep ulcer, but less than 25% of that circumference, or 25% of that width of the donut, and then deep ulcer of over 25%. Raised lesions, it looks nodular, kind of lumpy, bumpy here, can be very mild or quite profound, as you can see here on the right. Granularity can be absent, meaning you still have some glistening mucosa and normal vascular pattern. You can see this fine loss of vascular pattern here, and even more prominent coarse granularity. So those are the endoscopic features that clue us in as endoscopists to take those biopsies. And then the question comes up as to how many biopsies should we be taking, and how can we increase that diagnostic yield? We do think that EGIDs below the esophagus are also patchy, similar to EOE. And this was a study done as part of the Enigma trial, asking the question, how many biopsies do you need to take to increase that yield? And you can see here, as you increase the number of biopsies you take in that stomach, you increase the diagnostic yield. Same with the small intestine. As you take more and more biopsies in the duodenum, you increase that diagnostic yield. So we're really recommending a minimum of 8 stomach biopsies and 4 duodenal biopsies in order to increase that yield of making this diagnosis in patients. We know there's been a significant diagnostic delay in patients with non-EOE EGIDs, and this can certainly cause a significant impact on disease burden. Depending on the study that you're looking at, and the average diagnostic delay can be anywhere from 5 to 9 years prior to presentation. So why does that occur? Well, this is a study by Dr. Shahade and colleagues looking at the steps needed and required for the diagnosis of EG or EOD. First, patients need to have a classic presentation. So the tricky part with non-EOE EGIDs is patients may have non-specific symptoms and signs. Certainly a history of EOE or allergic diseases and atopic conditions clue you into this diagnosis. But if they tend to have non-specific symptoms, they may not get referred to a gastroenterologist. So there's a delay in referral to the gastroenterologist. They may be given an alternative diagnosis, such as irritable bowel, and there may not be a lack of thorough diagnostic workup, so they fall off the grid. If someone is astute enough to pick up on this, they get referred to that gastroenterologist, and then they need endoscopy with biopsy. And again, we just talked about that endoscopy and multiple biopsies are needed. However, perhaps they're referred, but there's no biopsies that are taken, or the biopsies are not sent to the pathology lab for histology. They're taken for H. pylori. Next, those biopsies have to have an appropriate histopathologic evaluation with standard staining and counting those number of eosinophils. But sometimes you may get a pathology report back without that quantification of the eosinophils, or there may not be enough biopsies that were taken to make this diagnosis. But let's just say all of these things are met. Ultimately, patients will get that diagnosis of EOG or EOD or other non-EOE EGIDs after other causes of that tissue eosinophilia are ruled out, and then can move on to treatment. But certainly we can imagine that these steps could take a while and really contributes to that disease burden. We looked at this specifically in our group together with our GI health psychologist, Dr. Bedell and Taff, and tried to assess the impact on health-related quality of life. So we took patients with EOG and eosinophilic enteritis, and they completed semi-structured interviews assessing common domains of health-related quality of life. And 4 domains really stood out: the psychosocial impact of diagnosis, so patients' mood before and after diagnosis, and a relief at actually having a plan once they got a diagnosis. There was impact on social relationships, such as missed work, school, social events for fear of getting symptoms and being isolated socially. Financial impact was certainly a burden, with financial costs with medications, formula food, and repeated procedures that are often needed. And the impact on body, from body image and strain on health and activity. High patient disease burden was also seen in a study by Dr. Jensen and colleagues. This was a cross-sectional study of a contact registry data. And what they found was that non-EOE EGIDs had more frequent and non-specific symptoms of nausea, abdominal pain, diarrhea, constipation, bloating, and a higher frequency of fatigue and isolation. How does this impact natural history and the disease course? Well, there's not a lot of data out there that sheds light on natural history, but there are a few studies that I'd like to highlight, and the one is by Dr. Pinatong. And what they did is they looked at patients and they classified them as EGE, and they defined EGE as any involvement of any segment of the GI tract. But for the purpose of this talk, I broke this down into segments. So in their patients who had gastric disease, they found variations in disease course really suggested chronicity of disease. So what you can see here in patients with gastric involvement only, 33% had multiple flares followed by periods of full remission, and 67% had a continuous course in terms of their symptoms, really suggesting chronicity. When they looked at the proximal small bowel, they found similar things. 20% had just one single flare, but 80% had either multiple flares followed by full remission or a continuous course of the disease, really highlighting the chronicity of these disorders. Another study was done in Japan. This was a survey study. They collected data on 786 patients, and 61% of them had non-EOE EGIDs, 62% in the small bowel, and 49% in the stomach. And what they found was that 66% of their patients had continuous disease. And most non-EOE EGIDs were persistent and severe. In their population, they found that restriction of activity, weight loss, surgery, and low protein levels were more common in their younger patients. So what do we know about outcomes and complications of non-EOE EGIDs? Well, we can take a page for what we know from EOE. So in EOE, this is a schematic on what we think happens. Patients start off with a normal esophagus. Due to some unknown trigger, eosinophils start trafficking to that esophagus. The esophagus starts looking inflamed, and you start to see those inflammatory changes. As time goes on, more and more eosinophils come. You get more fibrosis or scarring in the deeper layers of the gut, and you start to see those fibrotic changes. As time goes on even further, there's more and more scarring, and you start seeing a very narrow esophagus and fibrosis. We think of this happening as a continuum over time, with younger patients starting off over here with this type of inflammation, and as time goes on, progressing to the more scarred or fibrotic process. This is probably similar to what's happening in non-AOE EGIDs, and complications can include strictures, obstruction, perforation, anemia, bleeding, and malnutrition. Thankfully, similar to EOE, there's been no progression to malignancy that we've seen. And similar to EOE, there's been no predictors of disease progression or complications. So what I've shown you and highlighted with this talk with non-EOE EGIDs in 2022 is that they're not as common as EOE, but the incidence is rising. Males are affected as commonly as females, which is a little bit different than EOE. The revised nomenclature that has recently come out provides more precise terminology that specifies the affected region of the GI tract. The presentation is related to both the organ involved as well as the layer of bowel wall involved. And symptoms can be a bit nonspecific, but the common ones include abdominal pain, nausea, bloating, diarrhea, weight loss, anemia. Patients can have bowel obstructions, and you can see peripheral eosinophilia, so high eosinophils in the blood. Etiology is a combination of immune dysregulation, food allergy triggers, and a genetic predisposition. And natural history and outcomes suggest that this is a chronic disease similar to EOE, but really understanding true natural history and outcomes is an area of unmet need. So with that, I thank you all for your time and attention. Before I turn it over to the question and answer portion, I just wanted to highlight some research opportunities. So as I mentioned, we've been doing that analysis of the quality of life metric, and there is an opportunity to get involved in validation of the eosinophilic gastritis and gastroenteritis quality of life scale. This is a study out of Northwestern. We're looking for adult patients ages 18 to 65 with either involvement in their stomach or intestine or both. You can have involvement in your esophagus, but you just can't have only EOE. And if you'd like to participate, it's a short online survey. It should take less than 30 minutes. And here's the red cap link. Mary Jo and Jen will be distributing this after the talk. And the second study I'd like to highlight is through Seeger. This is for patients, teens and adults, ages 12 to 70 years old, with eosinophilic gastritis. The purpose of the study is to test the safety of dupilumab and see what effects, good and bad, it has on eosinophilic gastritis. And there's a link down here at the bottom if you're interested in learning more about the study to connect with the study coordinator at Cincinnati Children's. So I will leave that up now for a few minutes while I turn that back over to Jen to start the question and answer portion.
Wonderful. Thank you so much for your detailed description. I think the diagrams were really helpful to see everything as well. We've got some really good questions that have come in, and if you haven't submitted a question yet, please go ahead and open that Q&A box and you can start entering it there. So let's see, the first question we've got was about a personal situation and trying to understand the difference between some conditions a little bit further. So they wrote in, I was identified in 2005 with EOG. I have high amounts in the stomach lining, some in the lower esophagus, and high in the blood. What is the difference between EOG and hypereosinophilic syndromes?
So again, that's an excellent question. I think making it more general as opposed to answering that specific case, sometimes there's a lot of overlap with patients who have non-EOE EGIDs and very high levels of eosinophils in the blood. And that diagnosis of hypereosinophilic syndrome can be a little bit muddy. When we think about hypereosinophilic syndrome, we think about high levels of eosinophils persisting over a duration of time with specific end organ damage. And oftentimes that requires a diagnostic workup, including hematologic and oncological workup and bone marrow biopsy to look to see if there's abnormalities in that eosinophilic production. However, shifting it back a little bit, there's a lot of overlap with patients who have EOG or EOD or non-EOE EGIDs with really high levels of those eosinophils over 1500 that would fall into that hypereosinophilic category. But we don't think these patients have hypereosinophilic syndrome. It's just that their gut inflammation is driving these peripheral eosinophilia. And once they're treated for their gut involvement, that peripheral eosinophilia actually improves. But if a patient has that high level of eosinophils and it's persisting despite treatment of their EGIDs, absolutely, that is an indication to do further workup and see a hematologist and oncologist to specifically rule out hypereosinophilic syndrome.
Thank you. That's really helpful. Alrighty, so our next question is about the guidelines that you referred to. So people are curious, how long does it take to develop guidelines? And when might we possibly see them for non-EGID non-EOE EGIDs?
That is $1 million question, Jen. The short answer is a very long time. I'm joking a little bit, but it takes an awful lot of work and thought that goes into these diagnostic guidelines, because we really want these guidelines to be ready for clinical trials and clinicians to be able to use them. So the process in a very broad sense is we first start off with a systematic review, meaning pulling all the available literature that's out there on non-EOE EGIDs. And we look and do a very precise search on what is out there, both from the histologic aspect, from the clinical aspect, the endoscopic features, all these other areas. And then we create a consensus. So we get all the experts in the field to vote on these recommendations based on the systematic review. And then that formulates those guidelines. So there's a lot of discussion on that. There's a lot of people. This has really been spearheaded by the SIGGRAPH group, myself, Dr. Dallin, Dr. Fruta, and Dr. Estevez are really heavily, and Dr. Collins are really heavily involved in this process. So we're hopeful that within the next year, we'll have some guidelines out there. The key kind of little hiccup is that we first needed to get that nomenclature out there, because as you saw, even from my talk, a lot of the older studies all reference eosinophilic gastroenteritis, enteritis, and no one's talking about the same thing. So that was the first step, try to get everyone on the same page, and then we can develop these guidelines. So I'm hopeful that they will happen in the next year. And then the other thing to think about when we're thinking about clinical guidelines, there's certainly important guidelines for research purposes, but there's also importance to make it clinically relevant for the clinician, the average person that is treating these patients, to make it understandable and reasonable to use. If we put too many criteria out there, it becomes really a challenge for the average practicing clinician. So we really need to be mindful of that and make it relevant.
That makes a lot of sense. So once these guidelines are prepared, hopefully in a year or so, as you're saying, how can people find out about them? Should the docs know about them? Should people be sharing them with their doctors?
Yeah, so there was a really good campaign with the nomenclature guidelines that came out. They were published in Clinical Gastroenterology and Hepatology. And with the SIGGRAPH group, we had many of our junior scholars write a little piece, a summary piece that was put in the Journal of Pediatric Gastroenterology and Nutrition, in JACI, in Gastroenterology, and the Pathology Journal as well. So really disseminated that way. And it's also been a topic of many of the conferences that will be coming out. So yes, there is absolutely an importance and a need to disseminate this information, and that will happen.
Great. So diving back into some of the specifics of the nomenclature and things, one question that came up was around some of the conditions that are misdiagnosed. So you referenced a number of different conditions that might be confused as, and so people want to know, how often do some of these EGIDs get confused with Crohn's or IBD or IBS? What kind of questions should they maybe be asking their doctors?
Sure, and I think that's a that's an important part of this, is that the symptoms are very vague and, could be just some bloating or some abdominal pain and nausea, vomiting. It's hard to kind of tease that out if you're just going based on symptoms. And we want to be careful to not overdiagnose these conditions, but we also want to be mindful of having this diagnosis on our differential when we're seeing patients. So I would say the things that might clue a clinician in to really push to do that referral to get that endoscopy is, let's just say these symptoms have been chronic. They're really causing some impact in life. You're starting to see anemia, or you're starting to see eosinophils in the blood. The patient themselves are having other allergic conditions. I mean, that's the patient that really should be going forward and getting a more thorough diagnostic workup.
Okay.
And then the second piece of that is you were asking about the differences with inflammatory bowel disease, and that can be very tricky, and particularly if it's involving the colon, because many patients with eosinophilic colitis, ulcerative colitis, can have a pretty profound eosinophilic signature, and it can look a lot like eosinophilic colitis. So that's really comes down to looking at the slides and looking at the pathology with the pathologist and having them weigh in to see if there's some chronicity to some of these features, if they see anything called granulomas, which are a little collection of inflammatory tissue that would be more indicative of Crohn's as opposed to eosinophilic colitis. So there's a lot of additional information that we ask from the pathologist when we're concerned that maybe there's an inflammatory bowel disease picture.
Gotcha. So that's bringing up questions about scoping. So at what point is an extensive scope through the small intestines warranted?
So I don't think an extensive scope through the small intestine is warranted for every patient. I think we really need to be mindful of not trying to advocate for pan scoping people up and down. And I'm an endoscopist. I love to do procedures, but I really want to be very mindful of this and make sure that this information is coming clear. We really want to take each person as an individual. So, and think about their symptoms and think about their presentation. And the majority of time, we will just do an upper endoscopy, because in the majority of cases, we will find this diagnosis within upper endoscopy. But let's just say that patient is having a lot of rectal bleeding, a lot of diarrhea, then of course a colonoscopy, in addition to checking for infections, a colonoscopy is warranted, and we would do that. If a patient is not getting better with the upper endoscopy and the colonoscopy, or they're having persistent symptoms and we don't have a clear diagnosis, that's when I would start to do some imaging of that small intestine with something called a CT enterography or an MR enterography, and look to see if there's any involvement in that small bowel. And potentially, if someone has a persistent low protein level and we think they have a protein losing enteropathy, and that diagnosis has not been picked up by that upper endoscopy and the colonoscopy, that's when that imaging scan may be reasonable. Something called a video capsule study may be reasonable, or even what's called an enteroscopy, a balloon enteroscopy that looks through that large entire small intestine. But again, we want to be very cautious about kind of how we're approaching this and making sure we're doing this in a very mindful way, so that way we're getting the diagnosis with the least amount of procedures. We don't want to put patients through too many procedures that may be unwarranted.
Well, you hit right into the next question of how often should biopsies be taken to monitor the progress of disease? And also so I'm kind of combined two questions. You also talked about the number of biopsies needed to make a diagnosis. Can those be taken in a single procedure, or is it over the course of time?
Okay, so I'll start off with the second one. The number of biopsies that should be taken. Yes, we do advocate taking all these biopsies because it is very patchy. In our own practice here at Northwestern, we do what's called celiac protocol biopsies, which are at least 6 in the small intestine, as well as, that's 6 to 8 in the stomach. And those are all done in one session. When we talk about these biopsies, it sounds like, oh my goodness, so many biopsies. These biopsies are teeny tiny. They're about 1 millimeter, like the size of a pencil head. So really super small, considering the whole surface area of the gut. But we do want to take, at least that number of biopsies to make sure that we're getting adequate tissue. I always tell our fellows and our trainees to make sure that we're checking with our nurses that we're actually getting adequate biopsy. There have been some abstracts that suggest that sometimes, the biopsies get lost in the channel, they get lost and they're not actually put in the jar sent to the pathologist. So I make sure with our team that we have the appropriate number of biopsies in that jar before we move on to the next site. So I can't highlight that enough. That's what we found in the esophagus. We need the appropriate biopsies. We're going to find the same thing lower down. In terms of your first question on how often endoscopy should be needed, I think it's similar to what we advocate for EOE, in that if we're making a change in therapy, we need to be able to know that the therapy is working. And it's not enough just to go based on symptoms. So if I'm putting someone on a new therapy, or I'm decreasing their therapy, or they're going through, food reintroduction, and I want to know if their disease is active, then yes, I'm going to repeat that endoscopy. Once people are on a very stable regimen, I think we know less and less about how often we need to do these endoscopies. I would say, my own practice is to have someone come back at least once a year to make sure that we do a check-in on their clinical symptoms, and perhaps an endoscopy every few years, but it's very individually based. I don't think there's a blanket rule, but there are guidelines from the AGA, at least as it pertains to EOE, that if we're making changes in treatment, a follow-up endoscopy is reasonable. And I would imagine that the same recommendation will be made about EGIDs lower than the esophagus.
That's really helpful. Thank you. We have another follow-up question from one that was earlier. So they are interested to know, is it possible or common even that an eosinophilic disease can spread beyond the guts to other places in the body? Is it something that spreads or develops independently?
So I would say I will answer it in two different ways. In our experience and then the data that's out there, if patients have disease isolated to the esophagus, they tend to stay in the esophagus. They tend to be EOE patients. There are some people who may progress to have EOE and then over time get involvement in their stomach and their small intestine, but that's not as common. It's a little bit different and a little flip with people who have primary disease in their stomach and their small intestine. We have seen more transient inflammation in the esophagus from time to time, so that can spread a little bit, but they tend to have more of that primary disease, whether or not it's eosinophilic gastritis or eosinophilic esophagitis. In terms of spreading to other organs, like the liver or the lungs, if that's what you're asking about, or elsewhere, that is very highly unusual. And I would say, when we should be concerned about that is if we're thinking about patients with hypereosinophilic syndrome, and if that hasn't been adequately ruled out in someone who has really high peripheral eosinophils, then that should be. But in general, with our patients with the EGIDs, they tend to stay within the gut.
That's helpful. You have a colleague from Italy that has joined us today, and they have a question for you. They said they'd like to ask, what is the optimal continuation of therapy for patients with EOE under oral budesonide tablets for 12 weeks with histological remission, and in patients that doesn't reach histological remission? So I admit I am not trying to summarize that one. I'm going to let you handle that one, whether it's appropriate to discuss or not today.
If I understand the question correctly, so one, I would say the question was related to EOE. So with EOE, we know this is a chronic condition. We know that whatever treatment we're going to start someone on, we're going to keep them on. So we do advocate for maintenance therapy. And I'm not in Italy, so we don't have the access to, the dissolvable tablets. I can't comment on that. But what I will say is when we treat people with a topical corticosteroid, we will start them on high doses of that topical corticosteroid initially, do that endoscopy, make sure that that topical corticosteroid is working. If the eosinophils are quiet, the esophagus looks good, we'll decrease that dose down, but we'll keep them on that medication at least once a day at various treatment doses and keep them on that maintenance therapy. Typically, once I reduce that dose down and I keep them on maintenance therapy, I would repeat an endoscopy in about a year just to make sure that that inflammation is still quiet at that time. I think your second part of that question might have been if there are on the medication and it's not working. And that's when I would, really do a deep dive into asking that patient, are they taking their medication correctly? Are they, eating or drinking right after? Are they washing it down with liquid? I would make sure they're adherent to that medication. And then if they're truly refractory to that medication, I would think about other treatment options.
Thank you. Alrighty, we've got one last question for you today. So you talked about how the importance of doing endoscopies when treatment's changing. So this person has a question for food reintroduction diets. Their doctor is considering not doing endoscopies if their peripheral levels are in the low normal range. Is this sufficient, or should they be rescoped after each introduction?
Yes, and that is a really, really good question. I would say what's very challenging about the lower EGIDs versus EOE. EOE tends, most patients who go through food, at least in our experience, most people who go through food reintroduction with EOE tend to have just one food trigger. And the number of foods that we're taking away and the number of endoscopies that we're doing tend not to be too extensive. With not the lower non-EOE EGIDs, people tend to have many, many more food triggers. And those repeated endoscopies can be very challenging. If you have someone whose peripheral eosinophilia does tend to decrease with taking those foods away and increasing when they have that food trigger, we've done this in our own practice, that might be a good biomarker to use and to follow. The problem is that not everyone does that. But if you have someone who tends to have that reaction, that might be a reasonable thing. I think at some point we need to balance the true accuracy of doing an endoscopy every time we add a food versus how intensive and invasive that is for that patient with a number of endoscopies. And if we can come up with other suggestions like that peripheral count, that might be very reasonable for that particular patient.
Well, thank you so much for your time today. I'm gonna, as we start to wrap up here, just want to read a really nice comment that came in here for you. It says, Dr. G, your work is so important and your dedication is so appreciated. Thank you for all you do. So I just want to kind of reiterate that. Thank you for your time today and for the work that you're doing.
Oh, well, thank you so much. And thank you for this invitation to join you. As you know, I've been a partner with APFED since I was a fellow, so, like 17 years ago. And the work that, all the patient advocacy organizations are doing is just absolutely tremendous. And the fact that you're sharing all this information with the patients out there is just fabulous. And so I very much appreciate being invited.
We appreciate the opportunity to get to collaborate with you. I'd be remiss to also thank our education partners, particularly Abbott, AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, and Regeneron. We really appreciate their support of this webinar series. As you continue to think about future opportunities to engage with APFED, we hope you'll keep an eye out for more webinars in our series. Our next webinar will be on September 29th. We're going to sit down with Stephanie Skirka of Children's Hospital Colorado to talk about common questions that nurses hear about EOE. So stay tuned, registration will open on apfed.org very soon. Other opportunities to continue learning about eosinophil-associated diseases include watching on-demand content from our annual patient education conference, EOS Connection. While the live events happened this July, there's still an opportunity through the end of the year to watch all the content on demand. In addition to watching the live presentations, you can also browse the exhibit hall and the poster hall, which includes a lot of really wonderful videos from the researchers talking about their work. We also encourage everyone to continue learning more about eosinophil-associated diseases by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In the latest episode, our co-hosts Ryan and Mary Jo had a wonderful discussion about aeroallergens and EOE with Dr. Amal Assad, and we look forward to releasing more episodes this fall. You can find the episode and the whole series at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more podcast subscriber places. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again, Dr. Gonsalves, for joining us today for APFED's EOS Support Webinar Series and for your wonderful presentation.
Thank you. Bye-bye.
Bye. Wonderful. If anyone has any questions that didn't get answered today, please email mail@apfed.org. I hope everyone has a great day.